Hello everyone, and welcome to this IFST webinar, Transforming Food Systems for Those on Low Incomes, which has been organised by IFST's Food Science and Nutrition Special Interest Group. My name's Kate Halliwell. I am chair of that Food Science and Nutrition SIG for IFST. I'm also going to be your chair through the webinar today. In my day job, I'm the Chief Scientific Officer at the Food and Drink Federation. So when we were in the SIG and we were talking about what webinar topics we wanted to cover this year, there were two areas that really came through quite strongly, and we've tried to combine them both here. So the first was about huge inequalities that we see in diets and the impacts on health that this has, particularly for people on low incomes. The other was the fact that there's actually been a huge programme funded by UKRI, about £50 million over the last 5 years, looking into our food systems. And that is just coming to a close now. And so basically we were quite intrigued as to what that research had uncovered and what it showed in terms of how we can best support those people who need help most. So to guide us through what is actually quite a huge topic, we've got three brilliant speakers. Ayala Spiro from the British Nutrition Foundation is going to talk to us about what we actually know about diet inequalities. Dr. Tracy Duncombe is then going to give us a bit of a canter across the different food system programmes, particularly highlighting those projects that focused in on disadvantaged communities. And then last but by no means least, we have Professor Carol Wagstaff, who's going to actually really focus in on one of those projects, FoodSEqual. So in the interest of time, I am not going to go through everyone's biogs, but you will be able to find them on the IFST webpage for this event. And before I hand over to them, as just a few bits of housekeeping, I want to note about today's event. So the webinar is being recorded and it will be uploaded to the IFST's webinar hub. We're going to run the presentations all together. So each speaker is going to talk for around about 10 minutes, and then we'll take all of the questions in a Q&A session at the end. We'll try and get through as many questions as possible. I know it can be quite hard to remember your questions, so please do feel free as we run along to put any questions or comments via the Q&A button. You'll find it at the bottom of the screen. And then, as I said, we'll try and take as many of those as we can. You can also like other people's questions, so upvote them, and then that helps me to kind of pick through the questions because I'll know which ones people are really particularly interested in being asked. So with that, I'm going to hand over to our first speaker, Ayala.
Okay. Afternoon, everybody. I'm Ayala. I'm the Nutrition Science Manager at the British Nutrition Foundation. And thank you, IST, for inviting me to speak on what I think is a really important topic. But I'm just going to give you a really broad brush stroke insight into this area and then hand over to the other speakers to talk more about the research. So let's start and dive in with health inequalities. We know there's a stark association between deprivation and health. And we can see on the right-hand side that individuals living in deprivation live shorter lives. But not only that, they also spend longer parts of lives in poorer health. And this next stat really startles me, and it's the kind of thing that keeps us awake at night, that women in the most deprived tenth of the population can expect to live 19 fewer years, that's 19 fewer years of life in good health than the least deprived tenth. And the reason that that's so stark is that health inequalities by their definitions are unfair and avoidable differences in health across the population. Sorry, my screen's stuck. So I'm going to talk through some numbers, but I really want us to try and remember that these are people. They're not just statistics. They're people that have lived experiences of these conditions. So our Department for Work and Pensions report that 21% of people, that's sort of over 1 in 5, were in relative poverty in 23-24. And when we say relative poverty, that's below 60% of the median household income. And that includes 4.5 million children. And over 1 in 10 of these households have used a food bank within the previous 12 months. And poverty and food insecurity go hand in hand. And so it's interesting to note that 3.5 million people in relative poverty after housing costs lived in food insecure households, and that includes 1.4 million children. And what do we mean by food insecurity? Well, it means a limited or uncertain access to adequate and nutritious diet in socially acceptable ways. And I really want to highlight these words that it's not just the limited, it's also the uncertainty. And it's not just the adequate, but it's also around nutrition. It's also around making sure that people have diets that are important for their health and nutritional adequacy. I want to draw a little on the work of Dominic Waters, who was a food poverty advocate, who talks about these four pillars of food insecurity, just to give it some sort of illustration. Dominic lives in one of the most deprived blocks in a council estate in Kent, where access to nutrition is overlooked. The shop on the estate only sells the lowest food quality. So, ironically, in Kent, which is meant to be the Garden of England, it makes this a food desert. And it's not just income, it's also around fuel poverty. It's a regularly not having enough gas or electric to cook with raw ingredients. And when we talk about accessibility to a healthy diet, the bus never shows up. So even if people wanted to go out to a different supermarket to have the affordable, wider range of healthier foods, it's hard to make it out of the estate. So food poverty, as I said, is more than low income. It's also about limited transport. It's about poor housing and poor facilities, poor access. And this can be really exacerbated by poor physical and mental health. So if you live with food insecurity, you live with a precarious, uncertain, insufficient economic access to food and other material things like fuel and housing, and these can contribute to driving dietary inequalities. So poverty really matters in diet-related disease, and we see inequalities in the incidence of and death from diet-related disease, and in many common conditions that impact the morbidity of our UK population. So whether that's CVD mortality, cancer mortality, overweight and obesity, childhood obesity and overweight. We see that there is this inequality between the most deprived and the least deprived. So to talk a little bit more about inequalities in obesity, our data from National Child Measurement Programme really illustrates the inequalities in obesity. And here we have children aged 10 to 11 in our year six living in the most deprived areas, twice as likely to be living with obesity compared to those in the least deprived areas. And we also see that in an adult population, the adult prevalence of overweight and obesity is highest in those in the most deprived compared to the least deprived. If we just take one of those statistics, 37.4 living with obesity in the most deprived, 19.8 in the least deprived. Obesity is a public health concern and crisis, but we see this differential with deprivation. And when I was putting this slide together, I thought about the emerging area that we have of weight loss medication. We know it's radically going to change the landscape of obesity in the UK. But the availability of weight loss medications through the NHS currently remains limited, yet private provision has proliferated. So are we creating a two-tier system where we've got those who can afford them, have faster and more reliable access to treatment, and are we again fueling widening health inequalities? So back to diet, what we eat is important. Unhealthy diets are the primary drivers of obesity and preventable diet-related disease. And it's actually estimated that poor diets account for 13% of all UK deaths. But when we talk about diet, what do we mean? What are the dietary risk factors? And the Global Burden of Disease study eloquently shows this when they look at the leading dietary risk factors in ill health. And we can see that this includes things like diets high in salt, diets low in fibre, diets low in fruit, and low in veg, low in legumes, low in whole grains, the characteristics of our healthier diet. So these dietary patterns really do matter. And when we look at the NDNS survey, the surveys that show us what we eat in the UK and report on our nutrient intake, they report that children and adults on low incomes are more likely to have diets which are low in fibre, which are low in fruit, vegetables, and fish. So let's have that in a bit more detail. So fibre is low, the prevalence of sort of fibre intake being low is across the whole population, but for all age and sex groups in the UK, fibre intake increases on average with increasing income. If we look at 5 a day, we look at 11 to 18-year-olds or adolescents, 2.5 portions in the most deprived versus 3.3 in the least deprived. Sugar, an important nutrient that we're trying to reduce for obesity and for health. Both free sugars and sugar-sweetened beverages are highest in the most deprived quintile in all age groups. And I wanted to say something about status because that's really how we look at nutrient inadequacy. We look at the blood or biochemical markers. So in the most deprived quintile, 34% of adults, so over a third, had low vitamin D status, which is so important for our musculoskeletal health, versus 9 to 17% in the other quintiles. Sorry, my slides keep sticking. Just bear with me. Why is this? Why do we see these differentials? Well, certainly affordability is really, really key. And if you look at the research, the most common barrier is around the cost of healthier foods, the lower cost comparatively of unhealthier foods. But we really want to talk about the cost per calorie of foods. And I really love this diagram. So you may be familiar with nutrient profiling, the HFSS scores, which we use for advertising, regulation, and marketing promotion. So if there's a score of over 4, there's more restriction around sort of advertising and promotion to children. So here we see that the price per calorie of the healthier foods, the foods with the nutrient profile scores under 4, are much higher than those that are over the 4. The ones that are under 4 include the fruit and veg. The ones that are cheaper per calorie are looking at things like chocolate bars, sweets and crisps, but also things like fatty and processed meats. And when we look at all this, we really need to consider food waste because if you're in a low income household, you need to buy foods that will be eaten, not that will be wasted. And the Food Foundation do some really excellent work in this area. They've shown that the most deprived fifth of the population would need to spend 45% of their disposable income on food to meet the cost of UK recommended healthy diets, compared to just 11% for the least deprived fifth. As well as affordability, I just want to briefly touch on accessibility. That in deprivation, there's an easier accessibility and overexposure to energy-dense foods. So higher accessibility of those less healthy foods, HFSS and fast foods, but poorer access to healthier foods. And we talked when we looked at Dominic Waters' work about food deserts, those areas that are poorly served by food stores. If you think about an individual without a car or with a disability that hinders mobility, would have difficulty accessing a wide range of healthy, affordable food products. And some of the research I think is really interesting here. So, for example, the proportion of fast food outlets is higher in more deprived areas than compared to the least deprived areas. And also that people living in areas of higher deprivation are more likely to be exposed to unhealthy food and drink advertisements. So to finish off, what does that sort of indicate to us going forward? Well, I hope I've given a little bit of a snapshot about the kind of the holistic and strategic intersectional change that's likely to be required to tackle these very complex problems, the economic, social, and commercial factors that make it harder to eat healthily. But the actions and policies that are going to take place need to have less emphasis on the individual responsibility or the agency. In other words, they have to have less emphasis on aspects that require the individual's cognitive, psychological, material resources and time so that they can be more effective and equitable. There still remains a paucity of research on dietary interventions within the context of socioeconomic inequalities among underserved groups. And I'm delighted that Tracy and Carol will talk about this more, because engaging with disadvantaged communities is absolutely essential to better understand the factors that underlie their food decision making and the facilitators and barriers to empowering positive choices and the agency over foods consumed. And that's going to be incredibly important for effective policies and interventions. So I'm going to stop sharing there and pass on to Tracy.
I'm clicking the video, it's just not starting. There we go. Hi, thanks, Alea, and it's a pleasure to be part of this session today. So let me share my slides. Share. A bit clunky. Screen. Okay. So I'm going to give you a very brief introduction to the Transforming UK Food Systems programme before, as Kate said, giving a whistle-stop tour of research across our 16 projects, which is helping to support people on low incomes to eat healthier and more sustainable diets. So TUKFS is a £47.5 billion strategic priority fund investment, and it's a partnership across UKRI, as you can see, all the different bodies, and UK government bodies. So the case for making this investment started back in 2018 when Professors Guy Poppy, Patrick Vallance, Chris Whitty and Ian Boyd first discussed the need for structural and policy change to transform the food system to make healthy, balanced and sustainable diets easier to access for all. So they recognised that transformation of the food system at the national scale requires concerted action from government, business and civil society based on sound evidence from the research community. And since 2021, the TUKFS programme has considered the complex interactions between health, environment and socioeconomic factors, exploring potential trade-offs involved to ensure that solutions to problems in one area do not deliver at the expense of another. So our research addresses two principal questions. If we put healthy people and a healthy natural environment at the heart of the food system, what would we eat? How would we encourage people to eat it? And where would that food come from? So what would we grow and manufacture in the UK, and what would we need to import? Secondly, in delivering this transformed food system, what interventions would be needed across government, business and civil society? So on to the whistle-stop tour. So there's a huge amount of research across the programme that is relevant to today's topic. So I'm hoping I can represent some of the main themes. So firstly, the Fire Food Project has engaged with retailers to examine the impact of what food we buy on health, as well as the impact of mental and physical ill health on what people buy. So particularly looking at and working with people living with obesity and food insecurity. So the first report pictured here provides recommendations for policy and for healthcare professionals to address the underlying economic factors contributing to food insecurity and obesity. It makes a key point on the need to develop policies that don't stigmatise people living with obesity and food insecurity, for example, by including health and well-being rather than illness and body weight as a key outcome. Their recommendations include strengthening enforcement on marketing, advertising and product placement to minimise exceptions and building a national consensus on diet. The second report presents results related to the perceptions of supermarket interventions focused on facilitating healthier and more sustainable food choices. Not surprising to hear that the main behavioural change lever to purchasing healthier foods for those living with food insecurity was based on price and incentivisation, while the interventions perceived as least helpful were those targeted at consumer education. The point being that education might be helpful, but it's not seen as being enough on its own. The project has also supported collaboration between researchers, the IGD, and 4 major retailers to share data to enable an independent analysis by the University of Leeds to understand the impact of HFSS legislation. So the analysis found that legislation has been a force for good, leading to a significant reduction in sales of in-scope products, equating to 2 million fewer HFSS items sold per day across all eligible supermarkets. Importantly, the analysis showed the same level of reduction across stores in all types of neighbourhoods, including more disadvantaged areas where it's harder to access healthy, affordable food. But the team also found that it could have been better. So retailers had voiced concerns about complexities around interpretation and implementation, as well as limited enforcement. And shoppers with children and those living with obesity are still purchasing HFSS-dominated categories more frequently. And they're particularly susceptible to retail promotional strategies. which again supports the case for more promotions on fruit and vegetables. So moving to school meals, the Fix Our Food team has established a research and action partnership working across a number of school food focused initiatives. One of their biggest successes to date has been on auto-enrolment for free school meals. So I don't know if you know, but 11% of those children eligible for free school meals do not receive them because their parents simply don't apply. And we could probably talk for a long time about what those reasons are. So this project has supported the setup of auto-enrolment processes for free school meals across Yorkshire. So far, although these data are from a year ago, so it's probably increased a lot more, the project supported over 20 councils, enabling more than 20,000 children to gain access to free school meals. And that's also provided an additional £4.5 million of pupil premium funding to those schools as a result of the process. And the team are campaigning for auto-enrolment to be implemented on a national scale. The Mandala Project team has conducted economic assessments of the cost and benefits of extending universal free school meals, as well as options for subsidising meals to determine the return on investment under different funding scenarios. And their study has demonstrated positive returns on all options compared to current provision, driven by productivity gains and reduced household costs. Looking more at making healthier choices easier across institutional catering, staying with school meals for now. So the Bean Meals project looked to introduce more dried beans to schools as a way of increasing acceptability of beans for future generations, while also increasing the quality of school food. But getting children to broaden their palates can be challenging. So they worked with 6 schools in Leicester City and Leicestershire County in 2023. The collaboration provided cooking sessions with students and developed a game called Beantopia, both of which successfully increased children's curiosity and their willingness to try new bean-based meals. But the research also showed that working with staff right across the school when introducing a novel food such as dried beans was necessary to enhance the impact in the dining hall. So that's working with school management, so they provide the necessary leadership, with teachers linking beans into lesson plans, and most importantly, providing training to catering teams and lunchtime staff to support uptake. The project also explored the production and supply of UK beans into the school meal system, identifying the lack of processing infrastructure as a major bottleneck to roll out, as well as the current focus on public procurement rules that favour the lowest cost, which can hinder the uptake of healthier, locally sourced ingredients. Moving to Mandala again, they're trialling changes in Birmingham Children's Hospital to offer healthier, lower carbon menu options that are tasty and appealing and which align with nutritional and cost considerations that the hospital has to deal with. They're looking to identify dishes that are win-win, lose-lose or win-lose for nutrition, acceptance and environment, as well as looking to identify any unintended consequences, such as whether parents start to bring in more food from outside eateries, as well as whether new dishes involve additional costs such as staff time. The SNEAK project has taken a very different approach to guiding healthier choices. Their idea is to change the competition structure between menu items across a week and thereby influence the frequency with which more sustainable options are selected. So, for example, if a customer wanted to choose a beef burger on one day and a beef chilli on another day, by serving both items on the same day, they can only choose one. But no dish is withdrawn, no recipe formulation is required, and diners remain unaware of any intervention. So the team then modelled this approach using menus from 12 NHS hospitals across the UK, combined with responses from an online food choice task. And the results predicted that this approach could result in a significant reduction of up to 31% in the carbon footprint or saturated fatty acid intake. Bread. It's a big one for our programme. So white bread accounts for 76% of bread sold in the UK, which is around 12 million loaves being sold each day. Increasing the fibre content of white bread is highly likely to contribute to increasing overall dietary fibre intake, particularly among those on low incomes. So another project linked to school meals, this time breakfasts, is a partnership between the H3 research project and AB Mauri. So their collaboration has shown that white bread offered as part of school breakfasts can be replaced with higher fibre bread or bagels that meet children's taste preferences and for almost no additional cost. And they advocate for mandating such a change as an opportunity for a generational shift in eating habits towards higher fibre products. The primary focus of Raising the Pulse project is to integrate fava beans into staple foods such as bread to create more nutritious, affordable and tasty options that align with consumer preferences and dietary habits, while also making food production more environmentally sustainable. So the phrase was coined, putting beans in toast. The team has demonstrated that substituting even a small portion of white wheat flour with fava bean flour can yield substantial nutritional benefits. So replacing 50% of wheat flour with fava bean flour in bread increased fibre by 50% and protein content by 25% relative to a reference 100% white wheat loaf. And their early trials indicate that fava bean flour can replace imported soy flour as an improver in bread production and a proportion of white wheat flour without compromising taste or texture. And the team hope that the same principles could be applied to a variety of staple foods, including pasta, snacks, and meat substitutes. The Hi-Fi Bread project is focusing on developing new wheat varieties that can be grown in the UK, which contain more arabinoxylan, the main fibre component of white flour, hence allowing fibre intake to be increased without changing dietary patterns. If I'm okay, I've got one more slide on the research. The quality of food available within community food sector is partly limited by access to fresh produce. In many cases, end-of-life and poor quality surplus is offloaded to the sector, providing low-grade nutrition and often transferring disposal costs to community organisations. So the Mandala team are trialling a surplus food hub in Birmingham wholesale market, managed by a network of community organisations. And they're able to sort food into edible and inedible food. Inedible goes to composting, edible food goes directly to a network of organisations. And the hope is that changes in culture around food waste and strengthened relationships between the wholesale market and the community food sector creates conditions for collective purchasing, for example, via access to data of incoming overstocking. I'll not mention the other ones, but if you use the QR code, you can see other work that Mandala are doing on the viability of operating a social enterprise takeaway from using surplus food to produce healthy vegetarian food, as well as work on dark kitchens. So do take a look. More details of our findings as the projects are in their final stages. We've got a large body of co-produced evidence, and a lot of that has been gathered together in a special issue of the Philosophical Transactions of the Royal Society B, which was published in September. The papers are all open access. You can access them via the QR code. There's a final chapter that synthesises learnings from across the programme. It provides 27 recommendations that are for policymakers and others across the food industry that are characterised across 5 action areas. The recommendations show the UK can act now with practical steps that made food fairer and greener and more resilient. So thank you for your time. I deliberately haven't said anything about FoodSEqual project, which cuts across many of the themes I've already mentioned. So over to you, Carol.
Thank you very much, Tracy. And that was a great introduction for what I'm about to present from our other speakers. And with a bit of luck, you can all see my slides. So I'm going to give you a very whistle-stop tour through FoodSEqual, co-production of healthy, sustainable food systems for disadvantaged communities. I'm going to give you a very quick overview of what the main project was about, and then jump to its daughter project, FoodSEqual Health, for a last few slides, just to talk a little bit more in detail about one of the interventions. So FoodSEqual is a partnership between 5 universities by a number of major food businesses and the voluntary social enterprise sector. So all in all, we have about 50 partners from different sectors involved in it. So it's quite a big beast. And we said at the outset that we wanted to work with disadvantaged communities in particular to help them eat a more healthy and sustainable diet, on the grounds that if we could solve it for this sector of society, then it's probably going to help all socio-demographic groups within our society. And we really wanted to do it through co-production, by listening to consumers and to residents, to citizens, to find out what their aspirations were, what they think the solutions might be, and to co-develop products, supply chains, policies. And as you'll see, they're not sort of 3 separate areas. They all play off against each other. Ultimately, what we want to do is to have a more accessible and affordable food supply that enables people to make those changes towards a healthier diet, and to develop food policy so that disadvantaged communities can access sustainable and nutritious foods. And we heard from Aila about how difficult that is at the moment, particularly for this demographic that we're working with. So we work across 4 different communities. They're all disadvantaged. They're all in the most deprived areas of our country in terms of deprived wards, if you're characterising them by indices of multiple deprivation. They're also characterised by being right next door to areas of extreme wealth. I mean, Reading, this area of Reading Whitley, it is in the 20% most deprived wards in the country. But it's right in the middle of the Thames Valley, surrounded by some of the wealthiest areas. Brighton Hove, people often think of a place that's reasonably wealthy, but actually it's got a huge number of people experiencing homelessness. It's highly dependent on the gig economy. It really suffered during COVID and so on. Plymouth is a port city. There's one street in Plymouth where there's an 11-year difference in life expectancy between one end of that street and the other. High levels of child poverty, quite a lot of single people experiencing poverty, particularly those that have come out of the forces that have not perhaps adjusted back to civilian life. And then Tower Hamlets, right next door to Canary Wharf, in London, obviously. Quite different in the sense that there are lots of local street markets, so access to fruit and vegetables is not such a problem. It's not really a food desert in the way that the other 3 areas can be. Much more diverse, ethnically diverse, and with a strong sort of entrepreneurial sense around the place as well. So quite different characteristics for our 4 communities. But we used very common methods throughout, and I suppose that was really what FoodSEqual is about, is developing methods to work with people in the recognition that what's right for each community may be quite different. So the end point of where we get to is different for each community, but how we got there is quite similar. So we mapped current diets, we did a lot of work around the context of people's food lives, and capture people's aspirations. And this one, this set of pictures, just to illustrate something that we call the shopping basket exercise. And as you can see, it involved a lot of pictures of food and sticking things on walls and so on. And credit to a number of researchers across the project, Lisa Methvin and Claire Pattinger in particular, for just being amazing with having these very creative methods of research. Methods that would break down any barriers of literacy and so on, so that the research was really accessible to people, no matter to what their background. And I think we felt that we got good engagement and people really felt that they were valued in terms of what they were contributing to research. We got different responses, as you might expect, in different areas. And I just illustrate here the differences between Reading and Plymouth. There are some common factors. Food is stressful for many families. You've got stretched resources. The last thing you want to do is to buy food that goes in the bin. And that often drives people's choices. You'd rather buy food that you know the kids are going to eat rather than risk your budget on something that might be healthier but might end up in the bin. So yeah, price was a huge driver across all of our areas, but clear aspirations. People, they know what a healthy diet is. They know more or less what a sustainable diet is, but certainly in health, they have a real aspiration to eat more healthily and for their children to eat more healthily. The sustainability side was more variable. Interestingly, in Brighton and Hove and in Plymouth, which are both sustainable food cities that have won awards for those sorts of things, the awareness of the environmental side is much greater, and people would be willing to try and eat more sustainably. Whereas in the other areas, I have to say it's not really as much on the radar. Animal welfare and the environmental kind of aspects to our food systems didn't really feature in Reading. A little bit about removing plastic packaging, because that's something that people actually have to get rid of. But anything that was a bit further removed from that wasn't particularly on the radar. But a real priority that came out of both areas of wanting to eat a healthier diet and to try and have access, both physical and economic access to that healthier diet. So what do we say we would do? We said we would develop methods so we could co-develop product supply chains and food policies. We've done this through a whole range of community participatory action research methods. We've developed community researcher handbooks. So our community researchers are from those communities that we're working with, and we train them to be our researchers. So there's a real gain for them personally, and often it's a route into work. It's quite flexible work. You can do part-time. It fits around the kids at school and stuff. It also sets an example for others in the community as to what's possible. But absolutely critically for us, they get much better quality data, because if you're being asked questions and so on by someone of your community, you're much more likely to give an honest answer than if someone like me rocks up with a clipboard, and at best you might tell me what you think that I might want to know, but you don't get the honesty there. Our community researchers have been involved in developing policy briefs. They've been on our papers and all sorts of things, and now some of them are getting recognition for their community development skills through endorsement and through our training. We wanted to demonstrate a return on investment for that time. Co-development is often seen as slow, clunky, expensive, all these sorts of things. And we've developed a number of things. So in each of our 4 communities, we have 2 kind of sub-projects. Many of you will have heard of the Plymouth fish finger, which is just amazing. So this is using sustainably caught fish from fishers who use small boats under 10 meters. And it's the low value catch that they get that often would even be thrown back into the sea. So a really interesting piece of work around developing the blue food economy. That fish finger has been co-developed with schools and with a local company called Soul of Discretion, and they're now trying to scale up, and that fish finger will end up in the school food system, and we can happily come back to that later on. Oops, I just seem to have skipped through things. To discuss why that's possible in Plymouth. We've got toolkits for, in this case, for chickpeas, for increasing the consumption of those. Whether we can grow more culturally appropriate vegetables in the UK to serve the Bangladeshi community in Tower Hamlets. working with the British Nutrition Foundation on providing appropriate advice on the use of oils and fats, healthier snacks, and so on. We've developed evidence to underpin food policies. Our community researchers have contributed to the city food policy in Brighton Hove and elsewhere. We've got food partnerships in places that didn't used to have them, and so on and so forth. So I want to just spend the last couple of minutes just focusing on Fresh Street Community, which was an intervention that we ran with an additional lump of money that UKRI very kindly gave us to focus on health inequalities in our food system. And Fresh Street is Claire Elton's intervention that had been run in a number of places. It's basically vouchers for fruit and vegetables, plus the provision of those fruit and veg in areas that are often food deserts through local independent fruit and veg retailers. And we hung that onto community centres so that we were able to do this in very welcoming social spaces and also explore things like social connectivity. And alongside that, we did a load of activities that allow people to taste the food, to learn what they might do with it, to involve the children. So all of these very creative methods were running alongside the provision of the intervention. It's an area-based intervention, so it's not means tested. We basically picked streets that were in areas of high deprivation, and they got the vouchers. They were matched by control streets who didn't get the vouchers, but they got all the other information that was associated with it. We gave them £10 worth of vouchers every fortnight, plus a programme of community-based activities. And then we did what we call our foodie chat at intervals throughout the project, which asked questions about food security, about health, well-being, and does an intake 24, so we understand people's diet and diet quality and so on. And then we were also able to take samples for biomarkers and to do NHS health checks in each area. So what do we find? It's actually not that, it's not really rocket science, I keep saying. So if you give people physical and economic access to fruit and vegetables, and you provide the fruit and veg in terms of pop-up stalls and so on, they eat more of it. So in both locations, we found that fruit and veg intake increased by more than a portion a day over the 12-month period of the intervention. And we particularly shifted people who were not eating any fruit and veg to eating some fruit and veg. And I think that's really important. It's certainly enhanced social connection. Meet Peter, our local hospital team of nurses, who, as you can see, put on T-shirts, go out into the community hub and run the NHS health checks right there in the community. We are also able to do things like have citizens advice and other kinds of parts of the social care system in that community hub. We did cook-along sessions, there's a cafe there, all sorts of activities. And that meant that people met each other that had been living next door to each other, but really didn't know each other before this intervention started. When people eat a better diet, they feel better, and they are better. They have improved health. So, people are reporting weight loss, increased feelings of well-being, increased social connections. In Reading, we have the NHS health check data, and over that 12-month period, we saw an 11% reduction in obesity, an increase in healthy weight. We could see people moving through that process to achieve a healthy weight. Again, greater well-being, lower cholesterol, lower anxiety. And so this is all really good news. And I think it's great that we've managed to link the change in diet to health aspects. Our next move with this is to work with colleagues in Oxford to do something a bit like has been done in the States in this last part of the slide here. So we're going to try and do the health economics to try and use Oxford's prime time model to understand what this change in diet means in terms of the cost of healthcare and social care for treating things like cardiovascular disease and other diet-related diseases. And you can see from this American modelling that a 30% subsidy on fruit and veg over about 1 million healthcare customers would save over 40 billion in healthcare costs. This is slightly old data now, it's 2019, and we hope to bring it up to date and to bring it into a UK context. And so I'll leave you with that thought, and really happy that I can answer questions along with the rest of our panel.
It just remains for me to thank Ayala, Tracy and Carol for what has really been a fascinating webinar. Thank you all for attending today. Apologies if we didn't get to your question, but the speakers have all confirmed they're happy to be contacted afterwards. And when IFST shares the recording of this webinar with you, their details will be sent alongside that. The webinar is being shared with you, it'll be on your email. And it's also available from the IFST's online webinar hub. One last plea before you log off, please fill in our short survey. It'll launch as the webinar ends, and it just really helps us to understand what future webinars and topics that you might be interested in. And with that, thank you again to Ayala, Tracy and Carol and all of you for attending today.
My pleasure. Thanks.
Thanks very much, everybody.